Over and over again throughout the COVID-19 pandemic, we heard people say, just follow the science. And yet, when it comes to the issues of minors and gender dysphoria, we are now told, just follow the feelings. People will quote how the American Medical Association and other groups support children transitioning their genders. But while the group's name sounds impressive, what is the rationale behind the decision? What do the studies actually say? In 2016, under the Obama administration, the Centers for Medicare and Medicaid Services conducted a meta-analysis study in which they examined 33 peer-reviewed studies that looked at the effects of gender transition. Their conclusion? Well, it was significant, and I quote, "Based on an extensive assessment of the clinical evidence as described above, there is not enough high-quality evidence to determine whether gender reassignment surgery improves health outcomes for Medicare beneficiaries with gender dysphoria." Did you hear that? There is not enough high-quality evidence suggesting that it helps. In fact, the largest study with the biggest control group and the longest time duration, commonly known as the Swedish study, concluded that suicide rates were 19 times higher after gender transition and that there was a greater risk of death due to heart issues. The prescribed 4-step plan of social transition, hormone blockers, cross-sex hormones, and then surgery doesn't seem to actually help. This should not be surprising, as the major manual used in psychology, the DSM-5, noted that, quote, "The rates of persistence of gender dysphoria from childhood into adolescence or adulthood vary. In natal males, persistence has ranged from 2.2% to 30%. In females, persistence has ranged from 12% to 50%. In other words, the substantial majority of children with gender dysphoria do not need to change their gender. They simply grow out of it." This wait-and-see approach was particularly effective in the work of Dr. Zucker of the University of Toronto, where his approach was to address comorbidities before addressing gender dysphoria. In other words, addressing the mental and social needs of patients in holistic, talk-based counseling was more effective at addressing the real problems and, in most cases, resolve the temporary gender dysphoria. Dr. Ann Ware and Dr. Martina Shorkoff from the National Treatment Center for Transsexualism at Oslo University Hospital, Norway, also acknowledged the issue of comorbidity. Quote, "Our experience is that a large proportion of adolescents have serious psychiatric symptoms. These difficulties or concerns can be significant sources of great discomfort. In our experience, if these are left untreated, they may complicate the process of exploring gender identity and identifying solutions for gender incongruence. Our clinical experience indicates that not all mental difficulties in this group will necessarily be attributable to gender incongruence. Therefore, not all their afflictions can be solved by gender-affirming treatment." End quote. This suggests that changing the body does not fix the gender dysphoria. In fact, both Sweden and Finland have moved away from the old affirming approach for minors based on a review of data from the last 20 years showing a continued lack of reliable scientific evidence concerning the efficacy and the safety of treatments. Despite the science showing that there are other issues to explore, in today's affirming world, there's such a rush to simply affirm someone's momentary gender identification instead of letting the science and research drive the decision on how to treat an individual. So the next time someone tells you that all the science validates this transgender process for minors, ask them, what science? Because the best science right now is saying the opposite.